The QUO Podcast. Change your way.
Welcome to the QUO Podcast. I'm Ali, and today I'm talking to Dr. Ernest Hunter, who's a psychiatrist who has spent nearly 3 decades working on the front lines of mental health in remote Aboriginal communities. Ernest, thanks for taking the time to speak to us today.
It's a pleasure, Ali.
What drew you to work as a psychiatrist in remote Australian Aboriginal communities?
Well, coincidentally, I happened to be doing research in the Kimberley when the Royal Commission into Aboriginal Deaths in Custody was originally convened, which was 1988. The report came out in 1991, so 30 years ago. And it's tragic that in the 30 years since then, the issue that was ultimately identified as the critical driver of Indigenous deaths in custody, which was the overrepresentation of Aboriginal people in custody, has not only continued, it has increased dramatically. So we have 30 years past, the original problem remains, and I think that reflects fundamental issues which haven't changed over time.
What do you think some of those issues are if you look at mental health problems and the prevalence of things like youth suicide in remote Aboriginal communities from a historical perspective?
When the Royal Commission was first convened, the concerns that were raised related to the treatment of Indigenous people in custody, resulting either in deaths from suicide or, and it was suggested at the time, homicide. As it turned out, the majority of people who were in custody died of natural causes. There were about 100 people whose deaths were investigated. So the focus started to shift to trying to unpack what the drivers were, the social drivers, the political drivers, the other drivers for that overrepresentation in custody, because that hadn't been the case 30 years previously. And I was in the Kimberley at that time, coincidentally doing research on a number of suicides that occurred in the Broome region. It was a small number of suicides, but suicide had been extremely uncommon up until that time. And as I started to try and understand that particular phenomenon, I had to ask some other questions, and those questions included, well, if we want to look at increases in deaths from suicide, we have to first of all try and understand what the patterns of mortality over time have been anyway. As part of that, I started to look at records of deaths going back over time and identified that there were a number of waves of increasing types of mortality over time. And that led to asking the question, well, why has that occurred then? It's not that there's just suddenly a new kind of mental illness impacting Indigenous people. These are processes that are embedded in history, and so one has to ask not just what is happening now, but what's preceded it. And for me, that required doing 2 things. One was to ask some questions about the experiences of Indigenous people generally, and of course that varies enormously across the country, but also to reflect on how people who worked in my profession, in mental health field generally, but in psychiatry in particular, have thought about those processes, what the kind of paradigms of understanding had been, because those have changed very significantly, and the way you understand things informs the way you respond.
You've had an over 30-year career as a psychiatrist in this area. Can you talk a little bit about how those paradigms have changed over time and how you'd like to see them continue to change if you feel that there's a need?
Up until the mid part of the last century, the engagement of mental health practitioners in Indigenous mental health was really what I would call, in a sense, the paleopathology of the exotic. It was driven by curiosity. It reflected the work of a small number of people who went to remote Australia and described exotic phenomena. Some of that related to people who had serious mental illness, and occasionally there were Aboriginal people and Torres Strait Islander people who were brought to metropolitan hospitals suffering from serious mental illness. Not that many, but that certainly occurred. But what got into the press were the reports of people who, in a sense, straddled a borderland between mental health and anthropology, and were in remote Australia, where I think at that time people felt that the purest representation of Aboriginal cultures could be found, and that was a prevailing popular assessment in Australia and continues. So that continued right through until the 1950s, and it was only in the 1960s that that started to change. And the changes that followed over the subsequent decades really reflected particular individuals, because there weren't many people in my profession who were interested in Indigenous mental health really until the 90s or so. But in the 1960s there was a very important man called John Court, and John Court had trained in the United States. He was an Australian, and he was responsible for developing the field of what we'd call ethnopsychiatry. And what he did is he went to Bourke, he went to Mornington Island, he went to the Kimberley, and he went to particular parts of Arnhem Land and spent a lot of time trying to identify both the types of mental disorders that were present that you would see also in non-Indigenous settings, and to try and identify particular culturally specific conditions. And he was really a lone voice. He had a number of students who sort of picked up the mantle, but the next major change was in the 1970s. One of his students, a guy called Max Kamian, who was a general practitioner interested in mental health, went and lived in Bourke, and he wrote a book called The Dark People of Bourke. And he took the paradigm one step further, because he was keen to identify the sorts of problems that he was seeing in that community, in the reserve Aboriginal community, in other Aboriginal people. And he asked the question, why is it that there are these particular problems concentrated in particular spaces and particular groups? And his assessment was, well, given poor housing, unemployment, etc., we can't understand these issues without understanding the circumstances in which people are living. And from that there followed a series of interventions which were basically a social disadvantage frame. You know, people have these problems because they're socially disadvantaged. The response to that is topping up with social advantage. The next phase really shifted because that particular set of interventions didn't radically change the situation for Aboriginal people. So in the 1980s we had a new approach, which is a group of people, and I suppose I'm situated in that space, who said to understand the entrenchment of social disadvantage and the problems that go with it, one needs to understand the political context that people's lives are embedded in and that inform that. And that's a frame that I would call the social and historical frame. So that's been my interest over time. Subsequently, that has changed and moved on, and two important things have happened. One is that subsequently a new paradigm, or new paradigms have emerged. The issue of the control factor, understanding the impact of the maldistribution of goods in societies and of opportunities has taken the fore and been driven by public health. And the second is that we've had a dramatic change in Indigenous representation in health generally, but across the kind of academic space. So we now have Indigenous people who are driving the research and Indigenous people who are really creating the new paradigms of understanding.
And why do you think it's important to have that participation from Indigenous people, whether they're experts or community members, in driving, I guess, policy in this area?
Well, I think there are two reasons. First of all, because I think it's a fundamental right that Aboriginal people should have the same opportunities as non-Indigenous people, and if they have the same opportunities, I would expect they would also want to have the same positions that give levers to change. The second thing is that I think that that Indigenous people in those positions bring a different perspective and also have different suasive power, different opportunities to shift thinking within the Indigenous community, and to be able to make some of the different difficult calls that for Europeans as outsiders is hard to make when being critical in relation to matters that are cultural matters. So I think it's important that that's happened. I'm glad to say that Indigenous representation in medical training now has increased dramatically. And a friend of mine, Helen Milroy, was the first Aboriginal psychiatrist in Australia.
When was she registered?
About 30 years ago.
That's very recent.
It's relatively recent. And the first Aboriginal doctor was probably around the same time, whereas the first Maori doctor was a century before that. So the situations and circumstances are very different, but I think it's telling that it's been that late that these changes have occurred.
When you're talking about remote Aboriginal communities, are there significant differences in the mental health issues facing specific communities that you yourself have dealt with, and have they been impacted by external circumstances and historical factors, as you were touching upon earlier?
Perhaps a way to approach it is to reflect on the issue of self-harm. So when self-harm first started to occur in Indigenous populations in the north of Australia, it was originally concentrated in town populations, and it was concentrated amongst young adults. Over time, and anticipated several decades ago, that's changed, and it's shifted to become much more common amongst remote populations, and in the Kimberley, in the Northern Territory, and in Cape York, and more common amongst Aboriginal compared to, say, Torres Strait Islander populations. We can also look at certain mental health conditions and see differential distribution even within remote areas. So I've been involved in doing research looking at serious psychotic disorders and tracking those disorders over some 30 years in North Queensland. And when I first started working clinically there, those conditions were relatively uncommon. They certainly were no more common than in the wider society, and probably less common. That's now dramatically different. And the prevalence of those serious disorders in Aboriginal populations in far North Queensland is significantly greater than in the wider society, but also greater than amongst Torres Strait Islanders, even though Torres Strait Islanders are equally remote. Our research suggests that it's also greater than amongst Aboriginal people living in other parts of Queensland. And the key issue here is that the populations of Cape York have a particular history. It's a history which involves draconian ghettoisation of Aboriginal people in remote missions which were situated for bureaucratic expediency and where the transitions to a sense of a space of kind of quasi-autonomy have been quite frustrating and really have resulted in a kind of a level of a Clayton's autonomy, I suppose. And those issues, I think, have very significant impacts on the way in which identity is constructed, and that has consequences for all sorts of outcomes, including substance use, self-harm, etc. Some of those drivers have arrived in those Aboriginal communities as a consequence of development, but some have also arrived as a consequence of policy. So to give you an example, in the north of Australia in Cape York, when the government took over all of the missions in the 1960s for financial reasons and ran them for another decade, they had to confront the reality of transitioning those communities to quasi-autonomy. What they did was they created this bizarre self-governing status called Deed of Grant and Trust. And overnight these communities were theoretically self-governing, but in reality they were still controlled by the department. The government confronted a problem though, which is that they had to fund those communities. And the funding of communities across Australia is through taxation, rates and taxes. There are no rates and taxes in those communities. What the government did, the Queensland government really diverted Commonwealth funds to local purposes, and they did that by opening alcohol outlets in all of those communities and giving the proceeds from the sale of alcohol to those community councils for their running costs. That created a situation in which communities were reliant on the sale of alcohol for some fairly fundamental initiatives. It's a really invidious process. So when I arrived and would sit with council members and suggest ways of reducing total alcohol consumption for health purposes, I was heard, but it wasn't going to happen because that was compromising fundamental flows of resources. Ultimately, that was changed in the 2000s as a result of alcohol management plans, which the Queensland government brought into play, which were also quite draconian, but they did at the same time recognise that what they'd set up with the sale of alcohol benefits for Aboriginal communities was in fact a really poisoned chalice that those communities are still recovering from.
That's a really poignant example, because often the rhetoric around alcoholism in Aboriginal communities is one of blame, but in that example, and I'm sure in many other communities it was a similar thing, it was actually the government who sort of introduced that initial reliance on alcohol sales. So I can totally understand what you're saying in terms of policy needing to, I guess, reflect sort of, or understand, take into account what's happened to the community. So if you look at that example of self-harm, you were mentioning the comparison between the Torres Strait Island community and another remote community. Was it Far North Queensland or was it
Cape York?
Cape York, yeah. What is the policy around, suicide prevention in that community now? And do you think that the paradigm, is the intervention that's happening now working, or do you think it needs to shift to reflect more of a historical understanding of the external circumstances that have caused those severe self-harm tendencies and psychosis?
So I'd like to pick up on a couple of issues there. The first is the understanding of what heavy drinking and alcoholism means across time. When I first began doing research in the Kimberley, and I spent 3 years following up a large cohort of people and looking particularly at alcohol, there was a prevailing popular understanding that alcohol problems amongst Aboriginal people reflected some kind of genetic predisposition. That's been very hard to push aside, but there's absolutely no evidence that that's the case. And Aboriginal people clearly had pretty impressive role models when it came to drinking. And the understanding has come to be more informed by an understanding of social disadvantage drivers. And indeed that evidence was there quite early on. Around the time of the Royal Commission into Aboriginal Deaths in Custody, there was some research looking at alcohol use in New South Wales and making the point that the increase in Aboriginal alcohol problems didn't occur when alcohol became available for Aboriginal people, because the legalisation of alcohol for Aboriginal people varied by state.
Okay.
And it varied by location. So in the Kimberleys, for instance, it was not legal until 1972. In Cape York, although it was made legal, it was essentially unavailable in these, what I call dogged communities, really until the 1980s. In New South Wales, alcohol availability was fairly common early on. The big rise in alcohol as a problem, though, occurred in the 1970s and was really tied to economic issues. The 1970s saw dramatic transformations of Aboriginal engagement in the pastoral industry and in rural industries, because Australia went into a recession. We had an oil embargo, we hit double-digit inflation, and basically Aboriginal people were the first people who were let go. So there was a dramatic rise in unemployment. At that same time, the Commonwealth government started to become a lot more active in getting people enrolled in social security. So unemployment arrived at the same time as money, and it was really a process of people shifting into towns because there was no longer work in regional areas, and into places where they were often ghettoised, and social disadvantage was rampant that led to those problems. So again, those issues need to be kind of contextualised. The second point you made related to thinking about the differences between a population like the Torres Strait and the population of Cape York. It's interesting to reflect on those differences because they're phenomenal, they're huge, and not just because these are very different populations. The populations of the Torres Strait, although there are many Aboriginal people who live in the Torres Strait, are Melanesian in origin. They have family connections to Papua New Guinea. They have a particular history which engaged with Europeans in a different way to the Aboriginal people of Cape York. The Aboriginal people of Cape York engaged with Europeans primarily by being pushed off the land to make way for European activities. And Aboriginal people in Cape York weren't engaged in that process because the economic drivers for Europeans to go to Cape York were gold, timber, agriculture, farming and maritime industries. You didn't need Aboriginal people for that. Very different to the Northern Territory and the Kimberley, where the driver was pastoralism. And as a consequence, you needed Aboriginal people to run stations. Aboriginal people built the cattle industry in Northern Australia. As a consequence, in the Kimberley, the legislation which controlled Aboriginal people was the Masters and Servants Act. And the Masters and Servants Act empowered pastoralists with control over movement and lots of aspects of Aboriginal people's lives. In far north Queensland, Aboriginal people weren't engaged in that way, and the 1897 Act empowered missions to have control over Aboriginal people. So the process for Aboriginal people in Cape York was concentration and isolation. The Torres Strait was very different. The engagement with European people was really a set of commercial and ideological engagements. So what brought Europeans there were maritime industries, and they needed people to work in those maritime industries. And they brought additional people from the Pacific. And those people also brought Christianity. So although Christianity arrived with Europeans, the big wave that shifted the role of Christianity in the Torres Strait involved Melanesian missionary trainees. And Christianity was grafted into the social structures of the Torres Strait in a way that was radically different to Aboriginal Australia. And Torres Strait Islanders were significantly more engaged with the economic activities of the wider Australian society. And the majority of Torres Strait Islanders now live on the mainland and have been part of the workforce, particularly in railroads, etc., since the 50s. So it's a significantly different set of situations, and really underlines how to simply suggest that remoteness is a problem misses some of the nuances of these differences.
When it comes to policy making, like, is the policy in the Torres Strait vastly different to in Cape York? Because it seems like, given what you've said about the historical differences in involvement and participation, it really should be when it comes to mental health problems and how they're dealt with.
Well, I think the points to make from the direction you're going now is, one is policy needs to be localised. It needs to be relevant to the population that you're considering, and the populations across Indigenous Australia are very different. And it is, I think, facile to think that you can simply take, for instance, in relation to the issue of suicide, a colleague of mine who was invested in Indigenous suicide in Canada made the point that one of the problems was that they would go to a community, they would study suicide, they'd then go back to Ottawa and they'd make the DVD, which was sent to everywhere. And that just wasn't going to work. So I think localising policy is really critical. And if you're going to localise policy, then you really have to think about, going back to the point we were making earlier, about the representation and the real opportunity to lever change of Indigenous people from those spaces. It's only 15 years since the government overnight closed down the first and only elected organisation for Indigenous people across Australia. That was ATSIC. Now, ATSIC was supposedly a representative organisation, and when it first came into being in the 1990s, was put forward as a brand new political dawn for Indigenous Australia. That it can be turned off overnight, regardless of the reasons for doing that, indicates the limits of real control that is exercised. So my sense is that localising control and localising capacity to inform policy is very important.
Reflecting again on the fact that it's at the cusp of the 30-year anniversary into the Royal Commission into Aboriginal Deaths in Custody, and I guess the 30 years that you've spent in the area, what are you optimistic about the future when it comes to severe mental health issues in remote communities? Are there specific things that you think can and will be achieved in the next 5 to 10 years?
I am optimistic. I think you have to be optimistic. I think that once you start being pessimistic, you should give up the job because you entrench that. And particularly if you're going to be a leader in any of these areas and training people, whether they are Indigenous or non-Indigenous, your values and your attitudes are conveyed. I think that we've got different lenses for looking at these issues, and it's important to step back and reflect that the situations at their worst are concentrated in a very small population. The Indigenous population of Australia is not huge. The Indigenous population of remote Australia is tiny. In countries where, for instance, in Papua New Guinea, right to our north, nearly 10 million people, you've got a psychiatrist to population ratio of about 1 to 1 million.
Wow.
In Australia it's 1 to 10,000, and we think there should be more. So we have to put things into context. We're talking about a small population of Indigenous people in Australia. We should be able to do better. And in relation to health issues, we are doing worse for our First Nations people than the other 3 countries which have Anglo-settler populations and for which there can be comparisons made: United States, Canada and New Zealand. In fact, in some very significant work that was done decades ago, looking at the differences between health outcomes of the majority population and the Indigenous population in each of those countries, Australia not only came out as worst, but a number of important points were identified. One is that health seemed to do worst in those countries where responsibility for health devolved to local authorities rather than central authorities. So in the United States, which has the worst health system of them all in relation to equitable access to health service, Indigenous people's health status is best. The reason for that is that Indigenous health in the United States is all controlled by is centralised, and it's not left to local authorities. We see some of the issues of local prejudices in what is one of the highlights of Aboriginal history, post-contact history in Australia, and that's the 1967 referendum. So the 1967 referendum changed 2 elements in the Constitution, which are interesting but not relevant, and it passed with a 90% yes vote. But the yes vote, or the no vote, was directly proportional to the number of Indigenous people in the electorate. So the areas with the highest yes vote were Canberra, Tasmania, Melbourne. The highest no vote was Kalgoorlie, which goes all the way up to the Kimberley, and all of those areas with large Indigenous people. So that suggests that there is less sympathy, I suppose, for Indigenous issues when you take responsibility to local authorities. And historically in Australia, responsibility for Indigenous affairs has always been with states. And it was only with the 1967 referendum that the Commonwealth had a role in Indigenous affairs at all. So up until 1967, the Commonwealth had no role in Indigenous affairs. Wow. It was the responsibility of states. And the states had been so bad at it that when the British government gave Western Australia colonial self-government, they retained responsibility for Aboriginal affairs, because by that time West Australia already had an internationally bad reputation for its treatment of Indigenous people. Another issue, so one point that was made comparing those 4 societies of Anglo-settler colonial is that Australia is doing worse than the others, that the situation of Indigenous people is worse when it devolves to local rather than centralised organisations. The last is that when you subsume the disadvantage of a particular group, small group, within the disadvantaged of people as a whole, you lose sight of the unique factors of that. So if we simply say, look, why are we talking about Aboriginal people? There are lots of disadvantaged people. Why don't we just have programs for people who are unemployed? There's a surface appeal to that, which really appeals to a kind of a populist agenda, and it misses important issues. So that was reflected in some work that was done by Faye Gale, social worker by background, ended up, I think, being Vice-Chancellor at a university in South Australia, did some fabulous work. So one of the things that she did in the 1980s is she wanted to track the trajectory of Indigenous kids through the justice system. And what she found was Indigenous kids are more likely to be detained, arrested, charged, and then incarcerated than non-Indigenous kids. What she did, though, then was to control for social class. When she controlled for social class, all the differences disappeared.
Wow.
Now, so what was picked up by the press was, and I remember this, research shows Aboriginality doesn't inform. Now, the point was that if 30% of non-Indigenous kids fall into social class 5, 90% of Aboriginal kids do. The point being that the disadvantage is entrenched, is structural. And so I think that issue of kind of subsuming disadvantage within the wider, subsuming unique status within wider categories of disadvantage is particularly problematic for groups like Indigenous Australians.
It's a structural thing, and I guess it's linked to their Aboriginality, their identity, and the experiences associated with it.
And it's changing. You asked about having optimism. Well, you just have to walk around the city and see ways in which there is representation of Indigenous issues, Indigenous themes, Indigenous people. There is a consciousness now that was not present in my childhood. This was just not something that I could see at all, and it was what was referred to as the Great Australian Silence. That there was this kind of eclipsing of Aboriginal people until the 70s or 80s. We are in a remarkably different space now. We now have a generation of people who've been to university and who are embedded in political systems and are able to push buttons in different ways, but buttons still need to be pushed.
Well, Ernest, it's been really interesting hearing your insights. Thank you so much for being on the QUO Podcast.